And I work mostly at MicroCare for those of you who I have not met yet. And today I'm going to be presenting on hidradenitis suppurativa. The reason that I chose this diagnosis to present on is because I find the pathophysiology very interesting, and there are some new kind of treatment pathways that are available on the dermatology side, although how we would handle it in clinic and urgent care is quite straightforward. So hidradenitis suppurativa is a complex disease, and it usually has two components that have to be present for this to develop. So the first one is predisposition to having occlusion of the hair follicle. This is the primary inciting event. And then once the hair follicle is occluded, it tends to rupture beneath the skin, and this triggers a robust inflammatory response. And this inflammatory response is kind of out of proportion to what it should be. And that's what causes all the inflammation that then kind of triggers this cascade of events with hidradenitis suppurativa. So as far as epidemiology goes, we don't see it in Montana a whole lot because it does have a predisposition to African Americans. It's usually younger adults, so it tends to present between puberty and about 40 years old. It's more common in overweight individuals and much more common in women. It's actually a 2-to-1 ratio of women to men. Now, the pathophysiology is an interesting part of this disease process, and it's because it has to do with the apocrine glands. And the apocrine glands do secrete fluid like a sweat gland does, but the apocrine glands are attached to a hair follicle. And so if this apocrine gland secretes the fluid around the hair follicle and occludes that hair follicle, this is the inciting event for hidradenitis suppurativa. These apocrine glands are only present in the axilla, the groin, the buttocks, and sometimes on the breasts. Apocrine glands, like I said, drain through the hair follicle, and they are considered specialized sweat glands. And you can see from the image, sweat glands drain directly to the surface on their own, but the apocrine gland is connected to the hair follicle for its drainage. Now, looking at this pathophysiology, you have to have the follicular occlusion and then the follicular rupture, and then mechanical pressure adds to this, so the obesity component of having a lot more pressure in these intergenous areas, and then that robust immune response. There are some associated disorders with hidradenitis suppurativa. Metabolic syndrome is associated with this diagnosis, and there's also an association with inflammatory bowel disease. They seem to share some of the same pathogenic mechanisms of immune response, and acne is also associated. And acne in these individuals can be severe and very difficult to treat. So when we're looking at the clinical manifestations of hidradenitis suppurativa, the question that always comes to my mind is this HS or is this a simple abscess? And looking at this picture, this person, you can definitely tell is not a simple abscess as they have all of these tracts. But that's what we're trying to figure out when we diagnose HS, in which kind of direction we should be going. So HS usually has recurrent inflamed nodules, so these patients will come in and be like, I've had this before, this is usually what happens with it, and this is usually what improves my symptoms. The axilla is the most common site for this to happen. These are super painful, as you can probably imagine. They're all red and inflamed. They're malodorous, they drain, and they cause a lot of disfigurement because of all these sinus tracts. And so patients are often quite embarrassed about their symptoms and what is going on. Another clinical feature to HS are these double-headed or multi-headed comedones. So they kind of classify these as tombstone comedones, and you have multiple heads of one comedone. And those heads and those comedones can connect then and cause sinus tracts. Or tunnels underneath the skin. And once those form, they can last for months or years. and because of all of that inflammation and tract formation, scarring is a significant component to this diagnosis as well. So when you're looking at an individual that comes in with abscess or, multiple abscesses or inflammation in these intriginous areas, these are kind of the things that you would want to think about as far as differential diagnosis goes. And pretty much HS is a diagnosis of clinical exam. So there's no test that you can do to diagnose HS. It's just strictly, history and your findings on physical examination. There are some different clinical stages to HS, which doing my research, I wasn't aware of these stages in the past, but it just goes through kind of some more benign cases to obviously the most extreme cases in stage 3, and it's called the Hurley clinical staging. So stage 1 is an abscess formation. It can have a single or multiple abscesses, but they do not have sinus tracts or scarring yet. In stage 2, you have these abscesses present, and you start seeing sinus tracts and scarring. And then in stage 3, there's diffuse and involvement and multiple interconnected sinus tracts and abscesses and terribleness happening there. So I already stated this, but how do you make the diagnosis? And the diagnosis is based on history and physical examination. So complications that can happen with HS and these multiple abscesses, they can be both physical as well as emotional. And like I talked about before, there is a big emotional component to this, and patients being embarrassed about their chronic condition. So the physical components can be strictures and contractures that can happen in these intriginous areas from all of the scarring. You can get lymphatic obstruction, and so you can actually get lymphedema of limbs and genitalia from all of this inflammation. The chronic inflammation can cause long-term anemia, hypoproteinemia, and amyloidosis. There can be infectious complications because of those openings to the skin. They can become secondarily infected. There's also been some reports of arthritis as well as squamous cell carcinoma secondary to complications of HS. So how do we manage HS when we see this in the urgent care? First of all, it's important to listen to the patient, see what's helped in the past and worked for them in the past, and then kind of, use your clinical tools to figure out which direction you're going to go. And for symptomatic individuals that come in with a lot of pain, a lot of pressure, a lot of induration, symptomatic treatment with an IND is helpful. It relieves their pain. It is definitely not curative because this is a whole underlying inflammatory process, but the IND is more for symptomatic relief and pain control. Most of these abscesses that are associated with HS are sterile. So you're not doing the IND to try and get rid of infection. You're doing the IND simply for symptomatic control. I often had the question, seeing multiple of these over my career, could we be doing long-term harm by doing multiple incision and drainages on these patients? And the experts say there is no long-term harm. They're already having scarring. They're already having inflammation. So if it's going to give them relief, then go ahead and do a symptomatic IND. Antibiotics usually are not recommended in HS patients unless there's evidence of surrounding cellulitis, because once again, most of these are sterile. And if you are concerned about infection or can't really tell from clinical examination, then you should do a wound culture of the fluid to see if it grows out anything, and you need to treat them with antibiotics based on the wound culture. So when should we use antibiotics? If you are considering using antibiotics, this should be reserved for individuals that either have acute evidence of acute infection or cellulitis, or confirmed bacteria on wound culture. You want to use antibiotics for the antibacterial effects, but actually the dermatologists are also using antibiotics for the anti-inflammatory effects as well. So they're kind of treating HS similar to what they would treat bad acne with, or kind of long-standing acne, and using one of these antibiotics with antibacterial as well as anti-inflammatory effects for treatment. And the recommendation is, if you put an individual on antibiotics for HS, you should probably be putting them on those antibiotics for 4 to 6 months. This likely is not something we will do in urgent care, but just kind of a consideration to pass on to the patient that, hey, if I'm going to start you on antibiotics because I think there's an infection, there may be some utility in continuing these for 4 to 6 months once we get you into the dermatologist and, have a care plan set forth by the dermatologist. The choice of antibiotics, usually the dermatologists recommend tetracyclines. So these are the first line therapy for HS as well as for acne. And then the number one, tetracycline that is used is doxycycline. And so they say doxycycline, 100 milligrams BID, and for that 4 to 6 month time period. You can also use topical tetracyclines, and clindamycin comes in a topical lotion, which could be beneficial to use. It's safe to prescribe and may reduce the likelihood of recurrence by getting rid of bacteria on the surface. So acute management, what else can we be using? Steroids are also used for HS. Talking about topical steroids, it does not look like those are useful. It doesn't penetrate deep enough to decrease the inflammation. Oral steroids could be helpful, and so if you have acute flare, mild to low dose prednisone could be helpful to decrease the inflammation. And you probably want to do a 1 to 2 week course of prednisone, 10 milligrams, once daily would be the recommended starting place for prednisone. The third option for steroids would be intralesional, and these intralesional injections can be very helpful, but it's something that you should be comfortable with and have done in the past or been trained on. But to do the intralesional steroid injection, you would use triamcinolone 5 to 10 milligrams, and you inject it down. You want to get close to the hair follicle because that's where the apocrine gland is. Long-term management. So long-term for these patients, they should be referred to a dermatologist. They're going to have ongoing flares and need ongoing treatment, and dermatology is the best place for them to be. It is interesting with some of the new biological therapies. They have found that these are helpful with HS. So the TNF-alpha inhibitors are a new treatment for HS, and there is one that is FDA approved. Another treatment is surgical excision of the apocrine glands. This is performed by a plastic surgeon. It can be curative. So in some significant cases, this might be a very good option for patients, but obviously is quite extensive to get all the way down to the apocrine glands to excise them. Other therapies have also included anti-androgens and isotretinoin, which is Accutane. And then lifestyle modifications, losing weight, looking at diet, what is being expressed through those apocrine glands that is contributing to some of this inflammation could be lifestyle related. So advice that you could give your patients with HS beyond their acute treatment and beyond getting them into dermatology would be loose fitting clothing because the extra mechanical pressure causes increased stress in those areas. Wearing cotton underwear and avoiding the tight underwear over the upper thigh can be helpful for the groin. Not shaving in those intergenous areas of the axilla and the groin. Once again, avoiding pressure in those areas. Smoking cessation. They have connected smoking to increased inflammation and HS. And then weight loss. All of that extra tissue adds extra pressure to these delicate areas. So pearls for hidradenitis suppurativa. HS is caused by recurrent inflammation of the apocrine sweat glands. The apocrine gland is only present in the axilla, the groin, the buttocks, and possibly the breasts. The most common in overweight and young females, and females are 2 to 1 ratio to men, Black and biracial individuals. HS is not caused by infection. Draining the abscesses can offer immediate relief. All patients should be referred to a dermatologist and discuss lifestyle modifications of weight loss, smoking cessation, looser fitting clothing. Thanks for listening.